Hello, it is a pleasure to be here with you. I'm Dr. Nada Husseini from the Faculty of Dental Medicine, University of Medicine, Tirana. I will present the topic Removable Prosthetic Rehabilitation with a third impression of a completely dentulous patient with temporomandibular disorders. This is a case report. In fact, the stability of the traditional dentures, especially the lower one, remains the main problem. So in order to increase the stability of complete dentures, different methods have been used. Regarding the difficult clinical cases where we have a resorption of the residual ridge, the piezography technique is one of the techniques that can improve stability and the retention of the removable dentures. Regarding the temporomandibular jaw implications, the absence of natural dentition alters craniomandibular biomechanics. Reported temporomandibular jaw might include condylar displacement, disc malposition, flattening of the articular eminence. We think that it might be an increased risk of temporomandibular disorders due to the loss of occlusal support. Despite over 350 million people being edentulous, fewer than 10% of edentulous patients worldwide have been treated with dental implants. This is a small number compared to the whole figure of edentulous patients. So, in these cases, the piezography technique helps to achieve a better stability. The construction of the dentures, where the shape of the external surface is created according to the function of the muscles and in harmony with the oral structure surrounding the dentures, increasing so the stability and retention of dentures. A completely dentulous patient presenting with temporomandibular disorder symptoms, treated with restored vertical dimension, bilateral balance occlusion, neutral zone technique. The aim was to improve function, comfort, and TMG stability. The 68-year-old completely dentulous male had the same dentures for 8 years. He has achieved complaint mastication mainly on right side, intermittent right preauricular pain, which got worsened with hard foods, right cheek muscle soreness after prolonged chewing. No jaw noise, no locking, no limited opening was reported. During the clinical examination, the mandibular movements were within normal limits. A mild discomfort and maximal opening was observed. In palpation, the right TMJ had familiar pain in that area, and it was localized tenderness in the right masseter. No crepitus or clicking, which excludes degenerative joint diseases. Based on the diagnostic criteria of temporomandibular disorders, Axis 1, the diagnosis was made clinically local myalgia for the right masseter and arthralgia for the right TMJ. In the intraoral findings, we have a severe residual ridge resorption and non-uniform resorption, especially posteriorly. The old dentures won artificial teeth, unilateral occlusion, and a reduced vertical dimension. The treatment plan was the construction of the new complete dentures with increased vertical dimension of 3 millimeters, bilateral balance occlusion, neutral zone technique. Also, additional patient instructions were given were moist heat application, gentle mandibular exercises, and also to avoid parafunctional habits. The preliminary impression was made with alginate with stock trays, the definitive impression with polyvinyl siloxane, and the custom trays. The centric occlusion was determined, and in the centric occlusion record in the group of in the patient, it was recorded with Carwax at the position of the artificial teeth. In the trying stage, also it was recorded the polished area in the vestibular and oral area. In the first, the visual analog scale of pain was 6, and in the right preauricular area. After that, The TMG and masseter had a familiar pain in that, and the OHIP ident score was 32, which is a reduced oral health quality of life. After 1 month of follow-up, no joint or muscle pain was observed. A patient had an improved comfort and function stability, and the OHIP ident was 10. On 1 year follow-up, stable results, no recurrence of the temporomandibular disorders. The oral health impact profile ident was 6, so sustained improvement in the quality of life. Here you have the clinical cases where we see the intraoral view and the old dentures with artificial teeth. Here's the primary impression, and here you can see the piezography in the central occlusion record stage where the position of the artificial teeth is defined. Then it's the trying stage where also in this stage the piezography impression was made, the silicone and in the outer and inner surface. And after that, after checking centric occlusion, after checking aesthetic, and after checking phonetic, the dentures were finalized. You can see here the table with the good parameters, and first the denture stability was poor, and then it was good after 1 month and also after 1 year. Future directions should be other studies with larger cohorts, with long-term follow-ups, digital workflows where the neutral zone might be included in the CAD/CAM, implant-supported prosthesis, and in fact, it is need for standardized protocols for piezography and neutral zone technique. As a conclusion, the determination of the neutral space of the prosthetic equilibrium is realized through the third impression. For this purpose, the following can be used: the phonetic method or functional movement of periprosthetic musculature, and the combination of the two methods. Piezography in the lower complete dentures also uses tongue impressions, which help achieving the retention compared to the traditional dentures. It increases stability, denture retention, and patient comfort. Posterior teeth are placed in the correct position, leaving so space for the tongue. It reduces the accumulation of food in the vestibular area of molars, and also it provides an adequate aesthetic from facial support. Thank you very much. This presentation is made with support of the National Agency of Scientific Research in Albania, which we would like to thank you very much. Thank you, and looking forward to meeting you in other conference.